Hello everyone, and welcome back to our Wednesday night fertility Q&A. We are going to be joined tonight by Dr. Kenneth Gelman of IVF MD, and we are going to be answering questions regarding certain things that can happen after an IVF cycle and actually preparation for how do you prepare for a frozen cycle when you have certain conditions going on, such as PCOS, endometriosis, autoimmune disorders, all kinds of things. So we're going to be getting into a lot of the nitty-gritty tonight, and we're excited to also talk about some preparation strategies that might be helpful when you are undergoing any medicated procedure or just also trying naturally. So we're going to wait tonight to be joined by Dr. Gelman. When he comes in, we'll beam him up here. In the meantime, you guys please type in your questions and feel free to comment in the chat if you have any concerns. And we'd love it if you could forward this to a friend or a loved one that might be suffering with fertility issues or just has questions in general. So let's see, we are going to, let's see, Dr. Gelman looks like he's texting me, but I can't see the text because I'm live. So if he could type it in the chat, then I can see, or I'm not sure. So hopefully he can join soon. Oh, okay, let's see here. Well, let me take my headphones. Okay, is this better? Hopefully you guys can hear me okay. Oh, okay, better? Okay, good. Cool. I was using my, oh, there he is. Let me invite Dr. Gelman in. And I was using my new headphones, but apparently they're not working. Okay, there we go. Okay, cool. Instagram is doing some glitchy stuff lately, but so we'll be joined soon.
Hey there.
Hello, how are you?
Good evening.
I am struggling with technology today, I think so.
Oh, really?
A little bit, but we're good.
That's unusual for you.
Well, yeah.
It's par for the course for me, though.
Yeah, that's good. For those of you who don't know me, my name is Dr. Farrar Duro. I'm with Florida Complete Wellness. We are based in Hialeah Gardens, and we also work with patients from Broward and Palm Beach and Miami. And I'm going to be joined tonight by Dr. Kenneth Gelman of IVF MD. And for those of you who don't know him, we've worked together many years. He is an awesome doctor. If you guys ever have questions about anything fertility related or PCOS or anything like that, please, this is your chance to ask right now. And no question is a dumb question. I mean, we love hearing from you guys. We do have several questions that were pre-submitted, so we're going to go through those. But those are basically submitted to us through Instagram. But definitely go ahead and type your comments also or questions as we go along tonight. So welcome. All right.
Welcome, everybody.
So we'll go ahead and get started tonight. We have some questions concerning tonight, just preparation for FET, and then what to do if you have PCOS or endometriosis, conditions such as that, and then what happens after the transfer. So there's a lot of questions tonight concerning that. We just had another question pop up. So we'll kick it off with our question here. Will letrozole alter your BBT readings?
Letrozole, no, it shouldn't. I mean, if you're responding, you're going to ovulate. And when you ovulate, obviously that's what's going to affect your BBT. So, if it goes up, obviously you ovulated, or you probably did. It should go up at least one little thing on your temperature thing. So you should see an increase in your temperature, and that means you ovulated. So letrozole should not interfere. It should actually help you.
Very good. Yeah, I would think that maybe alters it in a good way. That's good. And we'll start with we had a few questions in Spanish. And I think that it was regarding spotting after a transfer, like 7 days after. What do you guys consider, would you consider that concerning if you see that? Because I know sometimes people do have spotting.
Yeah, I mean, spotting is always tough because, when you're using particularly vaginal products, some of the capsules and things like that we get compounded, they may be a little irritating, especially if they're placed too high up and they irritate the cervix. The cervix is very friable. It tends to bleed very easily. So there may be some spotting related to, local irritation. But, obviously there's always concerns and when anybody spots, and then, at that early a date, you don't know really what that is, but obviously that patient hasn't even had a pregnancy test yet.
Mm-hmm.
So we don't even know what that'll mean, but we'll see, and 3 days later, if they're pregnant, we'll have to see what's going on there.
Hopefully that's good news, but yeah, sometimes the progesterone can be irritating to the cervix as well, like you said. In some patients. We have a few questions coming up already. I like you guys' enthusiasm tonight.
Yeah. Well, before Thanksgiving, you're getting all your questions.
Yeah, get the questions in while you can. It's so important. Pick our brains. Like, I guess if you add up the years that we've been seeing fertility patients, probably like 50 years, I guess, if we add them both.
Oh my God.
Up, Yeah. We got 50 years here, guys. That's
I got a birthday Friday.
Happy birthday.
It's
awesome.
like I'm getting there,
Yeah. No, getting older and wiser. That's good.
Yeah, well.
Yeah. There you go. Okay, so what are the chances of having another miscarriage at 9 weeks, 4 days pregnant? Previous miscarriage in July at 4 weeks. I'm very sorry to hear that. That's from Shanice.
Well, that's got to be evaluated. I mean, that's you got to go to your doctor. You got to find out, what tests are available, and there's a certain order of things you ought to do. You ought to get a recurrent pregnancy loss panel. You ought to have an SIS. Make sure there's no scar tissue in there from any previous losses.
I think she might be pregnant. It looks like she's 9 weeks, 4 days pregnant.
Oh, she's pregnant now, or she lost the pregnancy?
It looks like, what are the chances of having another miscarriage at 9 weeks, 4 days pregnant?
Oh, well, don't panic. Don't panic.
Yeah, I think
Shanice
might be.
Let's be positive, and obviously I hope you're getting monitored. So obviously we're seeing what's going on, by ultrasound. If you had IVF, you just had a transfer, you'll get an ultrasound at 9 weeks by us, and then you'll be turned over to your OBGYN. So I think you should be okay. But sometimes there's no rhyme or reason why things happen. But don't panic. Just be positive and make sure you're getting monitored.
Yeah, and the chances definitely keep going down as you get further along, right? So,
Well, yeah, and then, just because you have one doesn't mean you're going to have another one. There might have been a good reason for the first one. It might have been chromosomally abnormal. This one may be perfectly normal. You don't assume anything at this point in time, and I wouldn't worry.
Yeah, and there's a question also before that about the negative after FET normal 7 days ago. I think if you're 7 days past FET, that's still a little early, right? So to be getting.
Well, what are they asking?
I guess is it normal to have a negative 7 days past FET? Because I would think you would wait till 10 days, right?
Well, depends on the test. I mean, some people, a lot of people do a home test when they're not supposed to. Mm-hmm. And Shanice, hi Shanice. They have these new these super accurate pregnancy tests now that might detect some positive beta HCG, well before the first quote missed period. So some people are doing those tests early on, and they're seeing positives, and they're following them every day and watching them darker when we tell them not to even test. So, at this point in time, I wouldn't read into anything like that until you get a positive, hopefully, test on 10 days, post your transfer.
Yeah, it's like torture. You keep testing like that.
Yeah, I wouldn't do that.
It's hard not to, I know.
I wouldn't do that.
And there's a question about ovulating late. So that person is asking, since she ovulated late, the doctor said to do IUI. Should I get a second opinion? Heard of women still getting pregnant on their own. Definitely you can get pregnant on your own.
Of course. Of course. Doesn't matter. I mean, as long as you're being tracked with your ovulation and we know exactly when you ovulate, when we do Femara or clomiphene IUI cycles, we track the ovulation. It may not be on day 14 or 15. Some women tend to grow a follicle a little later, and they, may ovulate day 18, 20,
Mm-hmm.
and we feel it's a good quality follicle. We'll trigger it and go for it. Particularly women with PCOS. I mean, we see that they may not respond on time, or as somebody else who doesn't have PCOS would, and we still would help them get pregnant. And we know women with PCOS get pregnant on their own when they have a history of not getting their periods for every 3 months or 4 months, and all of a sudden, boom, they pop in pregnant. Well, they ovulate at some point.
Yeah, definitely. And sometimes that's why it's hard to know if you're pregnant.
Yeah, there are women with PCO who sometimes they don't know they're pregnant. Absolutely,
Yeah.
and that's a problem,
Yeah.
And certainly if, let's say, if they missed a birth control pill or something, that could happen too. So you always have to have a little bit of understanding about that, and we tell women, you could be pregnant,
Mm-hmm.
and certainly if they're on a regimen for PCO, like they're taking metformin, and I tend to use a lot of metformin and maybe progesterone in these women to give them, a regular cycle, a regular type bleeding phase. And that combination may kick out an ovulation. After doing that month after month, the body starts to sense that, hey, this is regular. This is coming back to normal. I'm going to ovulate.
Mm-hmm.
And then the person takes her progesterone, doesn't get a period, and figures, that's my PCO, and doesn't realize that they're pregnant.
Yeah, yes. I remember we had a patient who was 4 months pregnant who had no idea.
Yeah.
And she usually had like 2 cycles a year. So we said,
Yeah. We know that happens. It's not
yeah,
unusual.
yeah, definitely. So
Yeah.
we have a question that popped up, dealing with thin lining issues. Have you had an experience using Letrozole to thicken the lining?
Well, letrozole, will help. I mean, I think, that's a tough situation. I mean, if you're doing a frozen transfer, or what is she specifically referring to? Thin lining.
Yeah, thin lining. Lauren, you can chime in if you're Lauren B 147. You can type in the chat if you have any other details, but I guess, I mean, how would you use that to work with the lining? It would be more to trigger ovulation, so that the progesterone would be high.
Well, we would use it, yeah. You'd use it in particularly, obviously, for ovulation induction, because it's clomiphene historically might thin somebody's lining after multiple cycles. So maybe that's what she's referring to. But, sometimes if somebody's maybe going to do a frozen transfer, I mean, in patients with endometriosis, I tend to use Femara, even in frozen transfer patients, to try to obviously reduce estrogen, but it should have positive lining effects in addition. So not specifically, in any other use that I can think of.
Lauren's chiming in here with it's a failed FET, several canceled, only 1 embryo left. So how did you get that lining? Really, I mean, we use acupuncture a lot of times. We work with, different types of treatment with, we have a fertility massage protocol that sometimes we've had patients where they've seen a difference, even by 1 millimeter, it's still positive, or
Yeah.
2. Sometimes it's just like a little bit thin, so we don't know the measurement, but we have our patient's feedback after they come back.
Is she asking about frozen transfer?
Yeah, so she's had several failed FETs apparently, and she only has 1 embryo left, so this is kind of crucial on the lining.
And she's had a thin lining?
Yes. Mm-hmm. So
Yeah, that's a tough problem, because that not only Femara, I don't know if Femara is really going to do that much good, but obviously increasing your estrogen, patches as much as you can. Some people try other things like Neupogen infusions that might help. Anecdotally, I've had a couple patients where it's helped. Viagra, not really much of benefit. It's a real tough issue sometimes to sort of thicken that lining, and we wrestle with it a lot. Now, I think I mentioned before in some of these things that a lining can still be receptive and still might be thin. And according to the fellows who designed the ERA, the lowest receptive lining can be 6 millimeters.
Okay.
You know, but theoretically, I saw some studies recently that, you know, 8 is the best, 8 or over. You know, so obviously we try to thicken it as much as we can, but, you know, maybe if we can't get it thickened in any way in this person, you know, maybe get the ERA test and maybe see if you're receptive, and that might give you some peace of mind if you eventually get a transfer.
Awesome. Okay. And adjunctive therapies, do you recommend anything apart from medication? I know you do recommend acupuncture for this because I know that we've had patients come for different things about with blood flow, but like as far as you know, as far as exercise or anything like that, I don't know, what's your opinion on that around this time?
On exercise for
An FET, yeah.
to thicken the lining?
Well, when someone has a thin lining. Because,
Well, I mean, you know, if I guess, you know, it's not really something that I think that's been studied, but it's not going to theoretically hurt things. I mean, as long as you're not overdoing it, but, you know, any kind of thing that can increase blood flow in general. But, you know, when you exercise, obviously you're increasing blood flow to a lot of places, you know, your muscles and etc., not so much your uterus. You know, so it probably has some benefit there. But
like mild exercise and not cardio, for instance.
yeah, yoga probably is the best thing.
Yeah, definitely.
Something like that, you know, reduce your stress and counter regulatory hormones and kind of fight against those things.
Fight or flight mode. Get out of that fight or flight.
You know, yeah, I mean, that's a big part of it, probably.
Awesome. Okay, and we do have someone who's 10 weeks tomorrow. Congratulations with her first FET, 42 years old, going in for blood work at IVFMD before stopping meds. No ultrasound scheduled. Should I ask for one before graduating from the clinic?
Well, I always do it. So yeah. I don't know which doctor you're going to, but maybe they don't. But I always do it at you know, 9 or 10 weeks before you leave. So it would be probably a good idea to get that. It'll give you peace of mind because, you know, I don't know what your OBGYN is doing, you know, whether they do it right away or not, you know, because some of these people, when they go there, they, you know, they get blood tests the first time and they don't see the doctor right away, and, you know, and then, you know, they don't get an ultrasound right away. So people panic. You know, it's nice to get an ultrasound.
It's good to graduate, but then it's stressful.
I think so.
Yeah. Okay, we have another question about 4 IUIs and 2 IVF cycles. Unfortunately, they failed. Should I stay with the same doctor and keep trying or get a second opinion?
What does she have?
4 IUIs and 2 IVF unsuccessful cycles. Looks like.
Well, you know, I mean, it's hard to know what the history is there. I mean, is it an older patient? Is she older? You know, did she have good quality embryos? You know, did she have PGT embryos that were normal and that were transferred? You know, so it's hard to know what to tell that person. You know, so we need a little more history there. But
she's 37.
Yeah, I mean, 37. You know, theoretically, statistically, you should be in still a pretty good category, or a little older, but it's still, you know, 38, 39, 40, you know, egg quality is really changing there. So, you know, what was your egg quality? Did you have good quality blastocysts? You know, were they rated well? Were they genetically normal? And then you were failing for that reason, or you weren't making blastocysts, or you were having fresh transfers? Were you having frozen transfers? You know, what is the history? It's hard to know how to advise that person.
Yeah, definitely. You know, we wish you the best, and hopefully it is going to work out very soon.
Yeah.
Hang in there, definitely. And let's see. Oh yes, so the heartbeat 163. This is the patient who's pregnant at 12 weeks. Is that a good number?
Yeah, it's a great number. That's a good number.
Awesome. Okay. Yeah. We're going to jump back into our questions that were asked earlier too. Let's see. What is the function of, this was in Spanish, los interlípidos que funciona hacen en la transferencia? I guess so. What's the function of the interlipids for the transfer? Or
well, interlipids we use sometimes to sort of, you know, curtail the immune system a little bit so that we can help, avoid either implantation or pregnancy loss, because we determine maybe that particular person might have a little overactive immunity that might be, impacting, what we do when we place the embryo in there. So we might want to, sometimes give intralipids. And, usually we check natural killer cell activity. And, we have a good reason usually for doing that most of the time. But occasionally some people who might fail frozen embryo transfers or, recurrently, or there may be no reason why they're failing. They have good quality embryos, good quality normal blasts, good thickened lining, and they fail. And sometimes we give it empirically, maybe, because we don't find much, or sometimes we use IVIG in some people. Because we think in our practice, we're one of the ones that we believe that the immune system plays a role here. And, some other doctors don't necessarily, agree, and they may not necessarily recommend it, although they may, recommend other treatments that are out there. But, so, in that particular person, I assume that there was something with her natural killer cells. Maybe she has endometriosis.
Mm-hmm.
Yeah.
Oh, definitely. And what could a abnormal APA blood work mean? Because talking about the autoimmune issues, like what do you think?
There was a few questions, I think, about that. And that's a big question because that one, there is a definition out there of the APA syndrome. And the definition, I believe, was really meant as a research definition. Because when you look at the definition that they had out there, it was, first of all, you have to qualify as having APA syndrome. You have to have 2 elevations of either the IgG or IgM, APA or anticardiolipin antibody, one of those. And you may or may not have lupus. You don't have to have lupus. 12 weeks apart.
Okay.
It has to be persistently elevated 12 weeks apart.
Okay. I did not know that part.
Yeah.
That's good to know.
That was the original sort of definition of this thing. And then the other part of this is that, some OBGYNs, might use a strict definition of that. And they say, well, you have to have sort of recurrent pregnancy loss 3 times, really in the second trimester.
Oh.
It's not so much first trimester losses, it's second trimester losses. And so who's going to tell the patient, you got this one elevation of your antiphospholipid antibodies, but you haven't had 3 second trimester losses. So go home and come back if you have 3 trimester losses. Now, who's going to tell a patient that?
Right.
What doctor is not going to want to intervene sometimes even after the first one, I mean, it's so painful for a woman to go through even one. I mean, so this definition drives me crazy because it's ridiculous. It's probably made up by researchers who have no idea what clinical doctors go through.
Right. Yeah.
Zero, So, I think you really should have some kind of evidence, though, that the elevation of any of those phospholipid antibodies is real. So if somebody comes with one elevation and they're asymptomatic, they have nothing in their history, like, for example, pregnancy losses, proteinuria, something with their kidney, a history of preeclampsia, a history, some kind of placental problem, or a history of clotting disorders, something like that. That could definitely be one thing that, could do it. So, I think, that's the kind of thing that has to be, relayed to the patient, that, you have to at least have some kind of evidence that this exists.
Yeah, definitely. Especially when there's treatment. There's definitely clear treatment out there for that. So, yeah.
Yeah, well, and then, somebody asked about the treatment. And I think somebody mentioned in that one of those questions that they had a positive APA. Should you start aspirin and Lovenox?
Mm-hmm.
Well, again, that's what I'm trying to explain. There's got to be good reason for you to have some treatment, that there's some suspicion just because you have this elevation. We probably want to make sure at least that we're treating you with some reasonable certainty that you got something like this.
Right before egg retrieval, I see that. Yes, tested positive for APS.
Yeah, before egg retrieval, that doesn't make any sense.
Yeah,
That makes no sense. Yeah, that needs to be looked at later on.
Mm-hmm. That's not going to affect their retrieval, though.
No,
Right.
It's not going to affect their retrieval, and it shouldn't. Somebody shouldn't have drawn that at that point.
Mm-hmm.
I don't know why they did that.
Okay. So, would you recommend them checking again prior to transfer, or long before?
Well, I mean, now that they've raised that, red herring, probably, I guess if they're getting a frozen transfer, while they're prepping, get 2 of those levels, maybe, 6 weeks apart, something like that, and see if they're still elevated. Or there's got to be something in that. Maybe there's something in their family history. There's a history of clotting or something. There's something there that would prompt a reason for it. And there are people who have, clotting issues where they really could have APA syndrome and it's missed.
Mm-hmm.
So, there's people who, might be on birth control pills, for example, and they end up with a pulmonary emboli.
Yes.
And everybody thinks, well, it's from the birth control pills, it causes hypercoagulation, blah, blah, blah. But there are cases where that's been clearly missed, and they've had APA syndrome, not the birth control necessarily causing it. So, it can happen in, a non-pregnant situation also.
Is that regularly checked in everyone who's going through fertility treatment, or is it just certain people?
Well, we should. I mean, I think we pretty much check it a lot because we do frozen transfers in people and things. We try to, check their history and see if they have a clotting history. And if there's any concern that they've had miscarriages, we might want to be a little diligent in looking at that. But the question is, how do you treat it? And in pregnancy, the main thing about the APA syndrome is that these autoimmune antibodies, I guess they're hypothesized to affect veins and arteries, clotting. Mm-hmm. So if there's no circulatory system early on, before, roughly 6-ish weeks or so, starting Lovenox there is not doing anything. Mm-hmm. So you might as well forget it. I mean, you would start the Lovenox and aspirin really when there's really a heartbeat. But, before that, you may want to use steroids, prednisone, and try to reduce the antibody formation in the first place. Mm-hmm. So, in addition to Lovenox, things like that, I use steroids. Mm-hmm. And I taper off the steroids once there's a good circulation going and good heartbeat.
Right, because if you're trying on your own, but you do have this, and you're not doing IVF, you're not really necessarily wanting to inject yourself with Lovenox every day if you're not pregnant, right? So,
well, aspirin probably at the very least I would do, but you're not doing anything to affect antibody formation or anything like that. So, that's why I think, sometimes steroids are useful.
And there was talking about FETs, frozen embryo transfers. What do you check before that happens? And, they're wondering like TSH, vitamin D. You guys have, I know, a slew of things you check for, but what are your key concerns, I guess, right before an embryo transfer, as far as labs, I guess?
Well, everything that person mentioned, a regular chemistry profile, CBC, that kind of thing, thyroid, vitamin D, yes, all those hormones and things like that. And again, maybe sometimes immunologic issues too, especially if this is the second one, the first one didn't work, or we're looking for potentially reasons for implantation failure besides a thin lining, et cetera, or an embryo issue. So the basic things are really is what's checked beforehand. Like that person mentioned, really.
Mm-hmm. Okay, good. Okay, and then we do have a patient who's trying to conceive her kid number 2 with PCOS, but she's worried about ovositol during breastfeeding, and the period has not come back, but her long cycle says period not back yet, but long cycle's normal. So I guess if you're still breastfeeding, it's still normal not to have
Correct.
regular cycles, even if you don't have PCOS. But I've not checked into ovositol during breastfeeding. Do you have any information on that?
I don't.
Mm-hmm.
It's myoinositol pretty
Yeah.
much. I think it's probably safe, but I would check with your pediatrician about that,
Mm-hmm.
or pharmacist to check in on that one.
Yeah, I mean, it's I've read it is safe to take during pregnancy, they say. So I don't know, but still.
Yeah, it's probably okay.
Mhm.
It's I don't think it's going to be harmful in any way. But again, I always tell people whenever they're breastfeeding or anything like that, always double check with their pediatrician and or pharmacist if there's any question about that.
Yeah, and we do have someone who's asking that she has a positive pregnancy test 16 days post trigger. So that's 14 days post IUI. Can it be a false positive? But by that time, the
No.
HCG is already out of your system. So, right? I mean, it takes.
Yeah, that should be a real one.
Congrats, Vicky.
Yeah.
Vicky.
Yeah. What kind of HCG was it? Avidrel? If it was Avidrel, certainly.
Yeah, I mean, I guess it would say, it doesn't mention, but how long does it take generally for that HCG to get out of the system?
Well, Avidrel is out. Avidrel's shorter acting than HEG, which IM HEG is much longer. It's about a week.
Okay.
But
Okay.
Avidrel's shorter acting, so that should be well out of your system.
Yes, definitely. Get a blood test and then you'll know for sure.
Yeah.
Definitely. And congrats. We love happy stories too. There is a question about there's a lot of post-retrieval, post-transfer, post-IUI questions tonight.
That's fine.
So that's good. That's what we're here for.
Yeah.
How many days post-retrieval is it important to drink electrolytes?
Is it what?
How many days post-retrieval is it important to drink electrolytes?
Well, I mean, if you're hyperstimulated, until you feel better, which can be up to about a week or so. But if you're not hyperstimulated, probably a couple of days is adequate. So it depends on, what your estrogen was, how you're feeling, are you bloated, were you told you have, mild OHSS, but that needs to be followed by your doctors too. If there's any concern there, they should also check your electrolytes, the blood work. And also, you might need some fluids or, rare cases, sometimes it happens, we have to drain some fluid out of people. They get a little third spacing, but, that doesn't happen too often these days.
Now that they make organic Gatorade too. It's actually not bad. Try it.
Oh, really?
Yeah.
I didn't know that.
They have it at Fresh Market.
What is
And
it?
the refrigerated
Organic?
stuff.
Or is it made by Gatorade?
Yeah.
What makes it organic? What's the difference?
It doesn't have any of the artificial colors and stuff like that. Yeah.
But was it clear?
I mean, they make it, I can't remember. I just had it one time, but it looks like, yeah, it was kind of like more, it's not like water, but they do have something that they're using for coloring. So I'm not sure.
Interesting.
But there's other
I didn't know
options. Yeah, maybe.
I didn't know that. Well, yeah, or Propel. Just get Propel.
Yeah,
Clear.
there's like all kinds of. What is the other? Different powdered ones that are better.
Yeah, I think is it Pedialyte? They make a higher electrolyte powder.
Okay. Yeah, Noon or those tablets, that dissolve.
Yeah, they make these tablets, and that you can put in there, make your own.
So it's safe. And we have another transfer question where it's in Spanish, so I'll attempt this. Mi transferencia fue 11 y siento nada, solo sueño y cansancio. I hope I said that right. It's basically like it's been a while, but 11 days, and they don't feel anything. So I think it's normal. I mean, just tired and sleepy.
Yeah. You may not feel anything. There's some women that come in for the first ultrasound. They say, I don't feel anything.
Yeah.
And I'm worried. A lot of women say that. Some women get really, nauseous, and within a couple ultrasounds later, some feel nothing.
Yeah.
So it's not abnormal. Don't
on the,
panic.
yeah, on the 11th. So it was like, it's been like 6 days that she had the transfer. So, and the progesterone can make you feel sleepy too, a little bit.
Yes, definitely.
Yeah, but hang in there. It's such a long wait. I mean, it's like 10 to 11 days, but it feels like
Yeah,
eternity.
yeah, it's
Oh.
tough. It's tough. There's no question about it.
We have an exercise question as well, so I know we addressed a little bit of that, but they're asking if Pilates, Pure Barre is okay for TWW. What is TWW? Do you
I don't know.
Okay, sure. Anybody chime in if anyone knows what TWW is. It helps my mental health and it's not too intense. So trying while something, I don't know. But I think, I mean, in general, like we mentioned, if it's something gentle, it's not like 2 week wait. Thank you.
Oh, wow.
Everyone's
Boy,
chiming
these
in.
abbreviations, who knows, you know?
Oh, that's good. Okay, thank you guys. All right, excellent. Oh, wow. Okay, we're the only two people in the world that didn't know what that
We
meant.
didn't know what 2-week wait was. TWW.
Okay, I
Wow.
understand that.
We just learned something tonight.
Thank you guys. All right, so yeah, what do you recommend after during the 2 week wait as far as exercise?
Well, you know, I'm an old-fashioned guy, you know, and I don't. I mean, look, women do all kinds of things, you know, when pregnant and things like that. I always advise if you've got yourself a transfer and you're lucky enough to get good transfer done and all that, take it easy.
Mm-hmm.
I would take it easy. I would make this work. I would do everything you can to make it work, because if you did something like Pilates, which is intense, and God forbid it didn't work, or you started bleeding or anything which may have nothing to do with the exercise, you're going to blame that.
Yeah.
And you're going to be sorry you did it. So I always tell patients, you know, if ever you have a question about doing something, don't do it.
Mm-hmm.
It's a very simple rule. And that's me personally. You can talk to other doctors. They may tell you other things. You know, maybe go out, you know, after your 3 days of bed rest. And I tell still people 3 days of bed rest. Some other doctors won't. I do.
Yeah.
After your 3 days of bed rest, go out, take a nice walk, get some fresh air. It's beautiful weather now. Go take a walk.
Mm-hmm.
And take it easy for the couple of weeks. And, you know, I realize it's, you know, it's mental too. You know, your mental attitude has to play a role here. But,
Mm-hmm.
you know, convince yourself in your head that everything's going to be fine. You're not going to fall apart. And, you know, if you miss exercise for a couple of weeks, it's not going to be the worst thing.
Definitely, and we still see our patients too with acupuncture during that time, because we know that there is a lot going on, and you know, anxiety. Sometimes your thoughts can be your worst enemy when you're waiting for that news. So we work with
Oh,
that
for
as
sure.
well.
For sure.
So
But try
things
to convince yourself ahead of time that this is the right thing to do. And,
Mhm.
you know, or speak to your individual doctor and get their opinion, and, you know, feel good about what you're going to do.
Mhm.
You know,
Yeah.
but, you know, if you're asking me personally, I would not do it.
Yeah. And does nutrition and low vitamin D make a vast difference to the egg quality during retrieval?
Well, we think it does. I mean, you know, I think there's been some studies about vitamin D and egg quality, and, you know, that's why we always try to normalize it. So, you know, make sure your vitamin D is, you know, up to snuff, you know, 30, 50, at least over 30. Probably around 50 would be ideal. And also, it's probably good for your immunity.
Mm-hmm.
So, you know, make sure that that's well replaced before you do your retrieval in the first place.
Very good. Yes. And, you know, we do have another question about endometritis. Oh, we haven't actually addressed endometritis in a while, but I had endometritis due to retained placenta from vaginal birth.
Yeah.
Second biopsy last year showed 4 plasma cells.
Yeah.
This year had chemical miscarriage. Let me read the rest of the question. With PGS, normal high-grade embryo. Is it possible my plasma cells increased and endometritis returned, causing the chemical? Thanks so much.
Yeah, it might. You should definitely have that looked at, since you had it before. And, you know, 4 plasma cells is just on the borderline for being, you know, suspicious or mild. You know, and also there's also some discrepancy sometimes between pathologists around town, depending where your sample was read. You know, I know in certain cases we've had some weird results, like where I've had situations where I can't get rid of the endometritis after multiple antibiotic treatments.
Mm-hmm.
And I've had, my partner, Dr. Wood, do hysteroscopies on them. And some of these people come back completely normal. No endometritis.
Uh-huh.
Even after some of the other pathologists keep reading it as such. So it's a little bit frustrating in terms of, the pathology reports. But, for the most part, I mean, we're going with what we get, and they're the experts. So, if you have 4 plasma cells, that's suspicious for having endometritis. So I would definitely get that checked before you did another frozen transfer. So you need another biopsy. I know it's not pleasant, but it should be done. And an SIS too. Make sure there's no more retained products there.
No, that's super important. Yeah.
Because that could cause the endometritis.
Yeah. I mean,
the irritation, the constant irritation.
Right. Okay. That's because sometimes people really don't know where it comes from, but
Yeah. Well, that's a definite reason right there.
Yeah.
Is somebody's had retained products. So that's why you need an SIS too.
Yeah. I actually,
or a hysteroscopy.
I think
or a hysteroscopy and a biopsy.
And you don't have symptoms. That's the problem. It's not like
you may not. You may not. You may not. Some women have spotting.
Okay.
We were talking about spotting before. In between when they're not pregnant, some women have spotting or a vague, feeling of abdominal discomfort, and they don't know what it is, or persistent spotting. They keep going to the gynecologist, and they find nothing. They don't. They do an ultrasound. Nothing. Try these birth control pills, or whatever. And it's endometritis.
Yeah, actually, I remember someone came to our office and they were trying to get pregnant for about 4 or 5 years. And they were given Clomid by their gynecologist. So said and they checked their tubes, everything's fine. Could not conceive. So I actually referred her to you and you checked and there was endometritis. So you treated with antibiotics. She got pregnant like within, I think, 2 months after it resolved. With IUI, with actually her first IUI, so she just delivered recently. But I'm just sharing that because sometimes it seems like it's something that you just can't see, but then you check and there it is. It's like it's been there all the time. So of course she was like, "How long have I had this?" I'm like, I'm not sure. Like I don't know how long it could be there, but maybe it's there for a while.
That's right, and it's a nuisance. It's a real nuisance problem, but it has to be looked for.
Yeah.
As I say to patients, we've got to unturn the stones. We've got to make this work if we can the first time, so you don't have to go through this multiple times. We've got to do our due diligence, and that's one of the things we've got to do is make sure you don't have something like that.
Yeah, super important.
Because that's treatable.
Right, if you know the right combination, right? Because sometimes it takes a few tries.
It does, and it may take several courses of antibiotics, and sometimes the big guns, sometimes several antibiotics together to get rid of it.
Yeah, do you see it coming back a lot with patients or not really?
Well, on occasion, or maybe it wasn't completely eradicated the first time, who knows? I mean, but you also have to try to prevent it. Once you treat it, make sure they're on probiotics, and eating extra yogurts, things like that, to try to overwhelm the bad bacteria with the good.
Especially after wiping it out with all those antibiotics.
Yeah, exactly. Then you definitely need probiotics with it. Yeah. So you make sure you take that and get a good one, from Whole Foods or, places like that.
Very good. And is it, okay, we did talk about, is it normal to have no pregnancy symptoms after FET? You guys are so helpful. Well, thank you very much. We're trying to be helpful. I think that we talked about this, and it is normal. Like a lot of our patients don't have any symptoms.
Most people don't.
Yeah.
Yeah. So that's not unusual. Don't worry.
Even in pregnancy, they're like, I just feel normal. I don't think.
Yeah. Some people have absolutely no morning sickness.
Yeah.
Some people have terrible morning sickness. Something, don't wish for it so much because, I know you want to have it because then you feel, oh, I'm pregnant.
No.
But once you get it, and sometimes people are miserable.
Yeah. That's where we try to do those PC6 points, those C-bands. That's where that point goes. It's like right on your wrist, the helmet nausea. So we do that prior to knowing if anyone's pregnant or not. After the transfer, we'll start doing those points right away. And I think it's helpful. I mean, I definitely found out when we didn't see our patients for about a month during the pandemic when everything was closed down. We had like 5 or 6 patients that were super nauseous and some of them vomiting. And I'm like, I just don't see that much when we start implementing these points earlier,
Well, that's great.
So,
That's great.
yeah.
Yeah, we should really make patients aware of that
Yeah.
more often.
Proactively, yeah, it's better. And unfortunately, we have a patient who had she's asking if she did anything to cause the chemical miscarriage she had. She didn't do any lifting, and she had top grade PGS normal embryos. Definitely not your fault, like I think we as women try to blame ourselves for so many things. And, especially a chemical pregnancy is devastating. And any miscarriage is devastating, but it's not your fault. And we hope that was a temporary setback, that next time is going to be a much better result. But I know with normal embryos, it's like it would make sense that it would stick. Like it doesn't make logical sense that it doesn't work. And that's the most frustrating thing, I think.
Yeah, I mean,
yeah.
there's it's not 100%. It's probably very close to 60% success rate. For a frozen transfer of a normal embryo like that, which is very good, but it's not 100. So there's going to be situations where you're surprised and it just doesn't work.
Yeah, we wish it was 100%.
Yeah, we're trying to do that.
Yeah,
everybody is.
No. And our heart goes out to you. So hang it in there. And if there's anything, that we can say, I think like having a support system is really important. So
yeah,
if you don't share what you're going through with people around you, it can be even harder to go through it alone in silence. So definitely reach out to a friend, a family member, and your provider.
Yeah. I mean, that person sounds like she's got a good prognosis ultimately, because she's making good quality embryos, and so that's a good thing. That's a really good thing. And just in this world of IVF, we're so scrutinized. Everything we do is scrutinized. It makes it harder. It really does. Yeah. Just think that there's hundreds and hundreds of women out there every day who don't even, miscarry, and they don't even know what's going on with their bodies. And, so
they didn't even know they were pregnant.
That's correct. And they miscarry too. And, so it's happening all over the world every single day. You can't always prevent that. And that's life. That's human nature. And, this is going to happen. And, so it's got to be something you have to accept and move on. But you're going to do well.
Yeah. Yes, we have faith. You will. And will an HSG show if you have endometriosis?
No, but it might show if you've got some kind of tubal problems or adhesions or something going on that might trigger the thoughts in your doctor that, hey, you got some kind of adhesions around your tube. There's no history of any chlamydia or pelvic inflammatory disease that you've had in the past. Maybe you do have endometriosis. So, maybe on further questioning, those painful periods, maybe that is something. Sometimes some of those people might end up, getting laparoscopies, and they, a good surgeon will find it or clean up the tubal issues if there are any. But if an HSG is completely normal, you're not going to have any inkling that there's endometriosis there. So an HSG specifically is not used to detect for endometriosis, just for tubal problems.
So we're down to our last 10 minutes of our Q&A, because we've been doing like lightning rounds,
Yeah, it's been good.
Yeah.
A lot of questions tonight.
Questions tonight. Yeah, I think these are really important. So we have a few more left, and we'll definitely answer these. We'll answer as many as we can in the next few minutes. How common is it for you to have patients with an average of 20 eggs per ovary? If yes, how many of those eggs end up being mature?
20 eggs per ovary is, it's 40. That's a good number. That's obviously a PCO patient.
Yeah.
Yeah, I mean, typically a lot, various percentages. I don't know exact percentages in most PCO, but a lot of them could be immature because with PCO it's hard to mature those eggs. We have to push those estrogens high up there to get the mature ones to grow, and then a lot of the little ones fall in behind it and just don't mature enough. So it's not uncommon to have immature eggs in that kind of situation. But as long as you've got mature eggs, that's a good thing. So, hopefully you do well. But that's not abnormal with somebody with PCO, especially when they have a lot of eggs like that.
And there's another STEM question about like what day when you have a good idea of like how many will be mature out of all those follicles, I guess, during stimulation.
Well, you'll see, your nurse or whoever's doing your ultrasounds will be counting your mature eggs, or what we think is mature eggs. And, your estrogen levels hopefully, will correlate. They might be a little higher because you have a lot of little small ones there that they can't count or can't see because maybe they're hiding behind the big ones. Mm-hmm. So by the time you go for retrieval, we'll know, roughly how many mature eggs you've got. And then obviously once your retrieval takes place, the embryologist will see, how many of those eggs are really, there. And then by the afternoon, when they strip them, etc., they'll see how many are mature and all that. So you'll have a better idea. Certainly by the next day, you'll know obviously how many fertilized.
Mm-hmm. Yeah, definitely. And there's another question about the person having another person having PCOS, and the first retrieval was unsuccessful. Oh, the first IVF was embryos did not grow past day 4. What to do to improve egg quality and have a successful second retrieval?
Yeah. Well, you had some fertilization, it looks like. Once they start to fertilize and they start to obviously grow, they have to grow appropriately. And if they stop growing at day 4, there may be some kind of egg quality problem there. So I think, going forward with your next retrieval, the question is, how's your stimulation? Was that a good stimulation? Did they overstimulate you? Did you have enough mature eggs there, or did you have not enough mature eggs? Did they try to fertilize, were the eggs immature when they came out? Mm-hmm. Because sometimes if the eggs aren't as mature, they may end up having to do conventional IVF on those eggs to let them incubate with sperm so that they mature a little bit more. Maybe that's what happened. And maybe those eggs just didn't do well after fertilization. But I would try again. I would make sure your PCOS is well taken care of. Make sure your androgens are down. Make sure you're on things like Ovasitol, metformin. That might help. Is your weight where it should be? Is your weight, is your BMI in a good range? Are you eating healthy? Are you eating, a lot of antioxidants? Is your stress high? Are you avoiding plastics exposure? Mm-hmm. I mean, things like that. Maybe try a different stimulation too.
Mm-hmm. Definitely. And sometimes looking at the male partner too, right?
That's the other thing is that the sperm. That's a very important point, actually. The sperm could be a problem. So, how is the sperm and how are the parameters there? Is there sperm disruption? Is there a lot of DNA fragmentation? Mm-hmm. Do you need to have that patient see a urologist? Is there a varicocele? Do we need to use testicular sperm? Because that's a variable we can theoretically change. Yeah. But try to improve your egg quality by the things I mentioned.
Yeah, definitely. And there is a question about, do I need to stop trying IUI if my TSH went up from 0.7 to 4.5 since I started fertility medication, Gonal F, and Femara?
Well, that shouldn't really have anything to do with it. So that person does not take thyroid medicine, or they do?
I wonder. I'm not sure. But this is pretty much all the information we have there. But definitely that's a big swing, right? So
yeah, that's a little weird. Mm-hmm. Is that a different lab that measured your TSH? Mm-hmm. Did you stop taking your thyroid pill? Did you do something like that?
Oh, it's just started today with thyroid medication, I think.
Okay. All right. So obviously that should get into your system over the next 4 weeks or so, and then have your TSH rechecked, and make sure you take your thyroid on an empty stomach, very empty stomach, and don't eat anything for a good hour, hour and a half. Take it only with water, and make sure your TSH is in a good range before you restart again.
Very good. Yes, definitely. That's important.
Yeah, because that's a little strange. Now, unless that person maybe had thyroiditis. Now that could have been it. Now maybe she had. Did you have thyroid pain? Did you have pain on your neck? Maybe you had a little subclinical thyroiditis.
Okay, so that's good to know. And I mean, would you recommend that person go see an endocrinologist?
Well, it's a little strange, yeah. I mean, if that was to the same lab and went from 0.4 or whatever it is to over 4,
Yeah.
in what period of time? Was that like 2 weeks?
Oh, no pain. She said no pain.
Yeah, but it could be silent thyroiditis that did that.
Okay.
There's something called silent thyroiditis. That's a little virus of the thyroid.
Oh.
I mean, that would be one thing that would cause a TSH to go shooting up there like that.
How do you check for that? Is there some other marker?
Well, you may not be able to check for it. Thyroid antibodies might be helpful. Where the TSH goes from kind of lowish to highish, could be a thyroiditis problem that the patient didn't know about. But if it gets better and it's treated, it's gone theoretically.
Okay, same lab she went to, yeah. So
yeah,
thyroid is
July. So that's like 3-4 months. Yeah, could have been some kind of thyroiditis. That's a big swing.
Yeah, I've been seeing that. I've seen that in a few patients lately. I don't know what's going on.
If it's the lab, if the lab is accurate, again, you're dealing with labs who are measuring the blood, and we're getting the results, and we're assuming everything's accurate. But that's a big swing. So I mean, I'm just trying to account for something like that. If it was truly real, what would account for something like that? Normally, you shouldn't have that. Unless you've had some kind of intervening issue that affected the thyroid that caused the TSH to go up, which might be thyroiditis.
Yeah, but you don't see it much with fertility medications as far as it affects.
No, the fertility medicines had nothing to do with that. This was just some kind of coincidental thing you might have had, But yeah, you can go see a specialist and see what they tell you, but there may not be much to do at this point.
Ultrasound helpful with the thyroid, or if somebody has?
Well, maybe they can see some kind of nodularity or something there that might, tell them.
Yeah.
Especially maybe there's a family history of thyroid disease, so that might.
Yeah. Okay, yeah, because definitely there's some thyroid questions coming in. I think the thyroid can get very wonky when you're pregnant too. So like right away, it's important to make sure that you get that checked the minute you get pregnant too. So my thyroid is normally 1.6, and after a May retrieval, it went from 1.6 to 3.4 in July. Then in October, it was at 3.6 with Placenta, went to 2. So it looks like that's that the centroid is working, right? If it went down to 2.
Yeah. I mean, you want it under 2.5. So that person's probably on thyroid pills, I would think, right?
Yeah, centroid.
Yeah. Make sure you're taking it on an empty stomach, so you absorb it.
Yeah.
And the TSH is going to vary a little bit, but you shouldn't be going from 1.6 to 4. That's a little weird.
Yeah, definitely is. Well, guys, we've reached the end of our Q&A time. So soon. But yeah, that really flew. So thank you guys so much.
That really went fast tonight.
Yeah, it did. Thank you guys so much for your questions tonight, and we appreciate you. If you would like to ask any further questions, you can reach Dr. Gelman at ivfmd.com, the website. You can arrange a virtual visit, right? Or I know maybe next year, right? Because you guys are really busy, I know, but definitely you can talk.
Yeah, no, we could squeeze in probably. I don't know what the schedule. I think we're busy till next year.
Yeah.
But please, if you have want virtual consults, anything like that, we're happy to do that. We do a lot of them for people out of state and different countries.
Yeah.
It's very easy to do. It's very fun.
Thank
Yeah.
you. You guys are
I
amazing.
had a patient from Norway the other day.
Oh, that's so cool. Yeah.
Yeah, it was
That's
great
so,
to talk to
we
people
live in
across.
such a crazy time. I mean, really,
Oh, it's great.
I'm grateful of the technology that we have
Oh, this is just
for this,
amazing.
you know. Yeah.
These guys who invented this, they're absolutely
Yeah.
brilliant.
Yeah. All right. Well, and you guys like to reach us, we're at Florida Complete Wellness, or you can follow us at FL Complete Wellness.
Do your acupuncture, everybody. Get your acupuncture.
Yeah.
Don't
Yes.
neglect that.
The world would be a better place if everyone had a little bit of
And
acupuncture.
everybody was calmer, right?
There you go.
We all need acupuncture and Prozac. Perfect.
There's a good company, yes.
And some turkey.
Yeah, and yeah, a little bit of vacation, which I'll be
A
on
little bit of
next
turkey,
week,
not too
so.
much. Huh?
Yes.
A lot of tryptophan in there. You got to sleep good.
Yeah, a little bit of melatonin, some
Yeah, yeah.
sunshine, and relaxation, and meditation a little bit. So
Yep.
let's all try. Let's make an effort next year, 2022, guys. This is your year coming up. I can feel it.
It is.
So thank you guys, and thank you, Dr. Gelman, so much.
My pleasure. Good night, guys.
Good night, everybody.